Should we start heart failure in continuation? Today we will discuss the three important investigations we use in a cardiology: the X-ray, chest, ECG, and echo, or blood culture. So today we will discuss chest radiograph and X-ray chest and ECG. Chest X-ray is a painless, non-invasive imaging test that uses X-rays to create picture of the structures within the chest, including heart, lung, and blood vessels, airways, and bones. So whenever in the cardiology we need to see the structure of the heart or lungs, especially in the lungs, we prescribe X-ray chest, and it indicates indirectly impression of the heart if there is a cardiomegaly and other structures we can identify. X-ray uses electromagnetic waves and ionizing radiations to create pictures. There are certain indications mostly related to the pulmonary and some cardiac disorders. So patients usually have a chest pain, cough, and respiratory distress. Whether it may be pulmonary cause or it may be in a follow-up patient that have previously diagnosed as a pulmonary disease, so we have to follow up the patient. We have to prescribe chest radiograph and pre-operative evaluation of patient that are planned for thoracic surgery and monitoring of the patient who have on life supports. So there are several indications to advise a X-ray chest, even in OPD, IPD, and intensive care units. So chest X-ray in cardiology is a basic mechanism, or basically we have to see in these patients X-ray chest rotation. How will you describe X-ray chest? So certain points or certain aspects you should keep in mind. Rotation, if there is a aligned or not. Inspiration, properly exposed. Projection is right. So rotation, medial end of both clavicles should be equally distant during the spinous process of vertebral body. You can see in this X-ray chest, the vertebral column in central spinous process is equally, and clavicle and medial end of the clavicle is equally distant to each other. It can markedly affect the appearance of the chest X-ray. Apparent mediastinal widening, tracheal deviation, if trachea is deviated, asymmetry in the lung density. By counting number of visible anterior and posterior ribs, so these are the anterior ribs and these are the posterior ribs. You can see yellow one is the anterior. In this X-ray, you can see there is two ribs. One is highlighted and one is faintly visible. So these are the anterior and posterior. So poor inspiratory efforts, there is fewer than 6 anterior ribs is identifiable, and adequate inspiratory, there is a 6 complete and anterior or 10 posterior ribs is visible. That indicate that is adequate exposed. Hyperinflated if there is a more than 6 anteriorly ribs. Poor inspiratory film can change the appearance of chest X-ray, resulting in false impression of the mediastinal widening or cardiomegaly. So inspiration should be proper. How will you project PA view or AP view? So X-ray beam should be in anterior or posterior. So the AP view and PA view should be important, and that's usually written in the X-ray film, that is AP view or PA view. So AP view always in the supine posture. Vertebral body is in clear in that X-ray, and scapula apparently cardiomegaly and clavicle oblique. Means AP view is for the bony structures and PU view for the parenchymal tissue or blood vessels or the bronchus. So AP view, there is a supine posture. PA view, there is patient is erect. Vertebral bodies are clear in the AP view. Prominent vertebral spine only. Apparent cardiomegaly. In the AP view, there is a apparently cardiomegaly that is not in real. So AP would never comment on the cardiac shadow. Exposure, in normally exposed, vertebral bodies are just visible at the lower part of the cardiac shadow. In underexposed vertebral body are not visible, but overexposed film, that is too black, that is overexposed. So too many photons have resulted in overexposure of the film. There is normal X-ray chest. Anterior ribs you can count, posterior ribs you can count, vertebral bodies faintly visible, and parenchymal tissue is well ventilated and well exposed. Inspiratory film. That is first one, medial end of the clavicle. Below this there is a manubrium of the sternum, and below of this there is a superior vena cava, and left side there is a aortic knuckle or aortic arch, and below of this there is a pulmonary trunk, main pulmonary trunk, and below of this in the left side there is a left bronchus, in the right side there is a right bronchus. Then there is a below there is a right main bronchus, in the same line there is a right atrium boundary, and below of this there is a inferior vena cava. So this right boundary of the heart is not a right ventricle, this is a right atrium. So right inferior vena cava, right atrium, right main bronchus, and superior vena cava on the right side of the boundary of the cardiac shadow. On the left side there is a aortic arch or aortic knuckle, pulmonary trunk, left main bronchus, and then left atrium, a smaller part of the left atrium in the left side, while right side there is a major part of the right atrium. In the left side there is a left main bronchus and then left atrium, then left ventricle, then diaphragm, both right and left, and both sides there is a costophrenic angle between diaphragm and costal margin. Assessment of the cardiomegaly. So we can assess by the cardiothoracic ratio, that is CT ratio. In your practical examination, examiner may ask if there is a cardiomegaly or not. So immediately you should. So that is A plus B upon C, that must be less than 0.5. And what is A, what is B, and what is C? C is the complete distance between two costal margin. There is maximum distance between left and right border of the costal margin of the diaphragm, and A and B are the maximum distance between left border and right border. When we draw a midline between two, then A should be a maximum distance and B should be a maximum distance, and then add A plus B and then divided by C. If there is a less than 0.5, that is normal. If it is more than 0.5 in adults, that is cardiomegaly, in more than 0.6 in the newborn, that is cardiomegaly. An increase in transcardiac diameter more than 2 cm compared to old X-ray, that should be counted. Pericardial effusion we can see by the X-ray chest. One is cardiomegaly, another pericardial effusion, that is different from the simple cardiomegaly. That is also cardiomegaly like pictures, but there is a different cardiomegaly directly proportional to the severity of the effusion. There is a rounded or globular shadow, you can see. There is a huge cardiac shadow that is typically globular in pattern. And cardiophrenic angle becomes more and more acute. Oligamic pulmonary vascular marking, there is a pulmonary marking are less. Leather bottle appearance, approximately 500 ml of the fluid must be in the pericardium to detect change in the X-ray chest. Usually pericardial fluid should be, normally कितना होता है? नॉर्मल पेरिकार्डियल फ्लूइड कितना होता है? टॉपर कहाँ गया? नहीं, कहाँ गई? Anybody? Yes. पेरिकार्डियल फ्लूइड जो होता है वो होता कहाँ है? ये तो एनाटॉमी का क्वेश्चन है. पेरिकार्डियम की कितनी लेयर्स होती है? अच्छा. कितना फ्लूइड होता है? नेक्स्ट. 400 500 तो पेरिकार्डियल डिफ्यूजन हो गया. That have to be an X-ray test only detection what there if there is by the echo we can diagnose even a 20 ml of the fluid. टॉपर है कहाँ? एब्सेंट है. पीछे बैठी है आज तो. ये 0.5 ml. 20 to 30 ml is normal, or approximately up to 50 ml we can say normal. If 400 500 ml is a severe pericardial effusion that should create to. अब तो जाने वाले हैं बेटा. It can be critical to diagnose pericardial effusion because if it is acute, it may lead to cardiac tamponade. ECG, electrocardiogram. You have seen all of you have seen the ECG. It's an electrical tracing of the heart activity that can be traced out in the form of electrocardiogram, and it is a non-invasive and device is called electrocardiograph. And August September first recorded ECG in the human being. There is some symptoms that alarm to do for the ECG electrocardiogram. The symptoms include palpitation, dizziness, cyanosis, chest pain, and syncope. If sometimes patient have a typical chest pain or atypical chest pain, but you have to do the ECG for the rule out the ischemic heart disease. That is important. If there is a pericarditis, if there is a pericardial effusion also, sometimes patient comes with a chest pain, and this chest pain should be ruled out by the ECG. Syncope, sometimes patient complains sudden onset of weakness, fatigueness, and sudden onset of the dizziness, chakkar, or unconsciousness. All these have a palpitation, so indication for the ECG. The sign some associated with the heart disease including tachycardia, heart rate is increased or slow heart rate, bradycardia, or some clinical condition like hypothermia. Patient comes in emergency with the hypotension or sudden onset of the high blood pressure. To detect the myocardial injury, ischemia, that is the foremost and the first indication of the ECG. Detecting the pacemaker or defibrillator device, evolution of the metabolic disorder in the form of electrolyte disturbances, hyponatremic changes, hypokalemic, hyperkalemia, all these can be assessed by the ECG. To monitor the pharmacotherapeutic effect, adverse effect of drug therapy in the form of any arrhythmia. So ECG has a multiple uses. There is conventional 12-limb ECG. It consists of a 12 lead divided into two groups, limb lead and precordial lead. Limb lead, we place the leads in the limbs, and some are precordial over the chest. So limb lead further categorized is a bipolar or augmented unipolar leads. Unipolar are AVR, AVL, AVF. Bipolar is first, second, and third. These all 6 are the limb lead out of 12. Precordial lead B1 to B6, B1, B2, B3, B4, B5, and B6. These are the precordium. Electrode are placed over the right arm, and left leg. Horizontally, it's V1 RT fourth intercostal space. V2 is the fourth intercostal space adjacent to the sternum. V3 between V2 and 4. V4 is the left 5 intercostal space in the metaclavicular line, and V5 is the anterior axillary line, and V6 is the mid axillary line at the level of the V4. V4, V5 and V6 in the same line but in different position. Strip is a paper strip that is a fixed 25 mm per second. Time represented horizontally, amplitude represented by the vertically. This is time and amplitude. One small square, that is important, 0.04 second. Exam में पूछा जाता है. One small square is equal to 0.04 second horizontally. In the vertically, that is one small square is 0.1 millivolt. So these are the some electrical events: P waves, Q waves. Next is QRS complex, T waves, ST segment, and sometimes U waves. So this is a normal electrical event. P waves. Why there is a P waves? P waves denotes atrial depolarization, atrial contraction. Whenever there is atrial systole or atrial contraction, by this there is a P waves. There is a two limbs of the P waves, right and left. Right limb denotes the right atrial contraction, left limb denotes the left atrial contraction. Then there is a ventricular contraction or ventricular depolarization, that's why there is a QRS complex. And between a P and QRS complex there is a small Q waves, that is septal depolarization. T waves is the again there is a ventricular get repolarized, and then the start of the atrial contraction and the atrial depolarization. So P waves, QRS waves, and then T waves. And between S and T there is a ST segment. In the ECG, complete ECG, we divide. There is an area of myocardium, that first and AVL, that denote the lateral aspect of the myocardium. V1, V2, V3 and V4 anterior or anteroseptal, and V5 or V6 is again lateral. Second, third AVF is the inferior leads or inferior wall. When we talk about the anterior wall MI, we are saying V1, V2, V3, V4 have changes. When we talk about the inferior wall MI, we are saying that the second, third AVF have changes. Steps of ECG. ECG should be recognized in the form of first rate, rhythm, axis, P waves, PR interval, QRS complex, ST segment, T wave inversion or upright, QT interval. So rate rate is equal to 300 upon large square in the 1 RR interval. So there is a 1 RR interval. The tall waves are the R waves, and between the two there is a 1, 2, 3, 4, approximately 4. And the 4 multiplied by the small square, and then 300. So 60 to 100 is a sinus rhythm, less than 60 or nowadays we say that the less than 50 is a bradycardia, or more than 100 is the tachycardia. Normal sinus rhythm if RR interval is in equally distance. You can see RR interval is in equally distance. There is no QRS widening. That is normal sinus rhythm. P waves is an upright. PR interval is the same. T wave is upright. QRS duration is same between successive leads. That is normal sinus. Sinus means in sequence one after another. HA node is acting as a pacemaker, you know. So each QRS complex is preceded by the normal P waves. Normal P wave axis is upright in lead 1 and lead 2. PR interval remains constant. QRS complex is less than 100. It's not wide. Another type is the junctional rhythm. That is AV node acts as a pacemaker. Cardiac axis, when there is a normal axis, lead 1, it's in a roughly idea, not exact. If lead 1 and lead AVF have a positive waves, then it means upright waves. That shows there is a 0 to 90 degrees. 0 to 90 degrees is normal axis. If lead 1 have a positive waves, but lead AVF have a negative waves, means that is reverse. It shows that the LED left axis deviation, it may be 0 to minus 90. In the graphical presentation you can see there is a just opposite to the normal. Extreme LED, negative or positive, lead 1 is negative and again lead AVF is positive, that is RAD, right axis deviation, means AVF is positive and lead 1 is negative. Both are negative, that is extreme axis, 90 to 180. ECG changes in acute MI, ST elevation, ST depression, T wave inversion, hyperacute T waves. These are the 4 changes you can see in an ACG of acute MI or myocardial infarction. New ST elevation at the J point. And what is J point? J point when there is a QRS complex and an ST segment start. That is J point. So new ST elevation at the J point in 2 contiguous leads. More than 1 mm in all leads other than V2 and V3, or you can say roughly there is a more than 1 mm ST elevation. More than 2 mm in the 40 years, more than 2.5 in the less than 40 years, and more than 1.5 in the women. That is the roughly criteria, but you should remember there is a more than 1 mm in the precordial leads is significant. In the inferior leads it should be more than 1. ST depression and T wave inversion is also shows acute MI changes. Now if you can identify what is going on in this ECG. Any idea? There is a ST changes, but कौन सी leads? Six rows first. आप ही क्या बेटा? You are saying the first lead, second lead, third lead, AVR, AVL, AVF, V1, V2, V3. Second lead. First lead is normal for your reference. Now you can identify easily. Inverted तो बेटा कहीं नहीं है इसमें. There is a clear cut ST elevation. ST segment is elevated in the second, third AVF. Have you got ST segment elevation? Second, third and AVF. There is a ST segment depression in B1, B2. That is reciprocal change. There is no inversion. So as second, third AVF we denote for which type of MI? Inferior wall MI, right? This is case of acute MI of inferior wall. Now this one. यही इसीलिए तुम्हारे एग्जाम में पूछे जाएंगे दो, या तो साइनस रिदम होती है या एमआई होता है. आप तो सोए गए. सो बोरिंग क्लास. अब बताओ बेटा. फर्स्ट ठीक है, सेकंड ठीक है, थर्ड ठीक है. AVR, AVL, AVF. AVR is always negative, so never comment, otherwise it's not correctly placed. Then B1, B2, B3, B4, B5, B6. This is again ST elevation in B2 to B1 to B6. No? एम्पलीट्यूड तो बढ़ रहा है बेटा. तुम बताओ. दिख रहे हैं? दिख रहे हैं ना? एम्पलीट्यूड इंक्रीज हो रहा है, कम हो रहा है? इंक्रीज हो रहा है. When I am talking about the duration, we are talking about the vertical amplitude. Amplitude of the ST segment is that is very high from the horizontal line. Horizontal line is the midline when the tracing start. See the first lead tracing is start. That is horizontal line. And see there is ST segment should be at that line. There is no ST segment at that line. Otherwise V1, first, second, third, AVR, AVL, AVF all have a ST segment on that line, but it's above the tracing line. By this we can identify easily by this. ST elevation, simple. It's a global MI. Anybody who can identify any defect in this? जो दिख रहा है वो बताओ बस, और कुछ नहीं है. वो कौन सा है, एमआई है, क्या है, उसके पीछे मत पड़ो. दैट इज द नेक्स्ट क्वेश्चन. एक होता है स्टार्ट फ्रॉम फर्स्ट लीड, फर्स्ट, सेकंड, थर्ड, AVR, AVL, AVF, then first B1, B2, B3. First lead is a normal sinus rhythm. उससे कुछ डिफरेंस दिखता है कहीं और? बता दो बता दो। खड़े हो। अरे आता है तो बताओ। नहीं बताइए। देयर इज क्लियर कट टी वेव इन्वर्जन इन V1 V2 V3। अब देखो दिख रहा है। V1 T wave is upright, P wave and T wave and R wave always upright. If they go negative, that is the fact. So V1 V2 and V3 the T wave is inverted. This is a negative wave. So third one is a blood culture. Whenever there is a bacteremia or there is an infection in the body, it may be acute or it may be a chronic, there is a chances of bacteremia or blood bacteria in the blood, and that's why we have to see the organism and see the sensitivity to antibiotics. So we advise blood culture. Sometimes patient comes you कि ऐसा 3 दिन तेज बुखार आता है, फिर नहीं आता, फिर 3 दिन 4 दिन बुखार आता है। कई बार पेशेंट कहते हैं सर लगातार बुखार चल रहा है 3 महीने से, 2 महीने से, 1 महीने से, 15 दिन से। So in those conditions we have to go for the blood culture to see the organism. So blood culture is a laboratory test used to detect bacteremia, fungemia, sepsis in a patient's blood. To perform the test, blood is drawn into a bottle containing a liquid formula that enhances the microbial growth it presents. That is known as media, culture media. You have already seen in our microbiology labs. Usually 2 containers are collected during one row, one of which is designed an aerobic organism and that are require oxygen, and another is for the anaerobic organism, that is anaerobic conditions. So 2 containers are referred to as a set of blood cultures. These are often collected from 2 different sites. That is important. ऐसा नहीं है कि अपन ने एक जगह से सैंपल नहीं लेना होता है, 2 जगह से लेना होता है at the same time. The usual incubation time of blood culture is 5 to 7 days at the 35 or 37 degree of temperature. Positive bottles usually signals in the first 24 and 48 hours also. Automated systems such as backtrack system is now introduced, and backtrack alert and track is considered incubator in which culture bottle are continuously mixed and growth is detected by sensor that measure the level of gases inside the bottle. And that gas is carbon dioxide, which serve as an indicator of the microbial metabolism. Microbial going in metabolic state. An alarm or some visual indicator are there that alert the microbiologists or the physicians to presence of a positive blood culture bottle. If the blood remains negative even at the end of incubation period, that is negative blood culture. Clinical feature when we advise for blood culture, usually in sepsis, patient have a tachycardia, tachypnea, high grade continuous fever, hypotension, in septic shock, or changes in altered in sensorium, or suspicion of infective endocarditis. Because infective endocarditis have a less bacteremia or less bacteria in the blood. These are the more the localized in the heart, in the endocardium. So fever of unknown origin is the third one. PUO, when you have suspicion of what is the cause of the fever. Systemic and localized infection, suspected meningitis, septic arthritis, or some prolonged anemia, pneumonia. When should you collect the sample? In case of periodical bacteremia and fungemia, blood should be collected at the beginning of the fever. When there is a come periodically, or during the chills or the start of the fever, we collect the blood for the blood culture. Or in case of continuous bacterium, we can collect at any time. It's better to collect the blood culture at the time of start of the fever. So amount usually 20-30 ml is blood collected from the 2 sides. So at least 40 ml blood should be used. Sample should be collected strictly aseptically. If endocarditis is suspected, at least 3 samples are necessary because there is a low blood bacterial count. Identification and susceptibility testing performed with Backpack system can identify gram-negative sepsis pathogens up to the 100%, but gram-positive up to 75%. Now, if there is a positive result, then positive, the lab will identify the specific type of bacteria or the fungal that causes infection. Then we advise for the sensitivity or susceptibility test that determine which antibiotic or antifungal is effective that particular organism. So certain antibiotics or antifungal drugs are used to see the sensitivity to that organism. Sometimes some are resistant, some are sensitive. So treatment is based on that result, and doctor will choose appropriate antibiotic. Before that, we can advise for the broad spectrum antibiotic that cover both positive, negative, and fungal infection. So sepsis, positive blood culture can indicate sepsis and life-threatening condition. Common pathogens are the following: Staphylococcus aureus, Pseudomonas, Streptococcus pneumoniae, Streptococcus beta hemolyticus, Listeria meningitis, Listeria enterococcus, Salmonella, Brucella, Pasturella, Hack group, and usually in the fungal there is a Candida. Anaerobics rarely seen. Microwaves are usually clinically significant even if they are cultured from only one of the 4 or 6 two bottles. So reports come in this form. There is trial pattern, 48-hour incubation, 37-degree temperature, date of collection date of reporting. Sample type is blood sample, and organism labeled as or identify E. coli. Colony count is important, that should be in a significant. So it shows more than 100 or 100 million colonies per ml. Such are the antibiotic like amikacin, amoxicillin, ampicillin. Some are sensitive, some are resistant. So reports come in this form. Thank you.